Good afternoon and welcome to the breast cancer Q&A webinar. I'm Dennis Holmes and we have Sharon Merritt. Sharon, would you like to introduce yourself?
I'm just the patient advocate. And I'm also a cancer patient, stage 4, but my scans are clean, so I guess I'm good for now, but hopefully for a long time
You're here.
or forever.
You're here. Well, I'm a breast cancer surgeon and today's topic is breast cancer cryoablation. We had questions that Sharon was able to assemble from a number of people through social network, and she's going to present the questions. Before we get started, I'd like to at least update you and also the listeners and viewers regarding some of the kind of developments in the breast cancer cryoablation world. Some good, some not so good.
Oh.
At least on the good side, you should know that I recently attended the American Society of Breast Surgeons meeting, and I was a participant in a course to teach breast surgeons how to do cryoablation, with the goal of educating more how to do so. The society is interested in developing its own registry or trial that will enable its surgeon members to offer cryoablation and then to enroll them in this common registry. And there's a pretty strong interest in that, and I think that's going to probably mature over the next 1 or 2 years where that trial will be available. That's my hope. And so that's on the good side.
Will that help start getting the insurance companies to recognize it, maybe?
It's a start. I mean, the more surgeons do it, the more patients have access to it and become aware of it, the more they ask their health plans about it. That'll raise the awareness amongst plans. And then as the society develops data about patients that are treated and develop some outcome data about how they do, then that'll give health plans kind of the information they need, and the societies the information they need to support cryoablation. So it goes hand in hand.
I mean, I would think, I could be totally wrong, but I would think that cryoablation is a lot cheaper than having surgery and reconstruction.
It is, but it's the decision maker is in part the health plans. But what they look to are national societies like the American Society of Breast Surgeons, like the American Society of Clinical Oncology, like the NCCN Guideline. These are like these independent, presumably independent, physician-based society that endorse treatments. And so those societies generally look for randomized trials in order to draw conclusions about the effectiveness and safety of a treatment. And then they'll say to a health plan, we endorse this treatment. So, I don't want to cut the health plans too much slack, but what they look to are the societies to provide them guidance, because that's where the expertise exists. And if the society recommends to them treatments that ideally are more cost effective for them, then that's where there's like a perfect marriage, data and cost effectiveness. Now, on the negative side, I was part of, and I don't want to disclose too much because I have some non-disclosures that I have to respect, but I had been an advocate for a randomized controlled trial of lumpectomy against cryoablation. That is the gold standard of comparing the standard treatment against the new treatment, and had been working with a company that initially had embraced development of that trial, and I, in fact, was going to lead that trial as the principal investigator. But I was tremendously disappointed about a month ago when I was told that they would not move forward with that. And that's exactly the kind of trial that we need to provide societies with the data that, cryoablation is as good as lumpectomy for the right patients, so that they can then, advocate for that among health plans. So I think that's a bit of a setback, but there are, this ongoing effort with the American Society of Breast Surgeons. So hopefully we'll get some more forward progress. So the last update I'd like to make, and because we're going to kind of reference it a number of times a day, and we linked it to the announcement, is that, that long-awaited publication that I had mentioned before has finally been published online. It's called Breast Cancer Cryoablation in the Multidisciplinary Setting, Practical Guidelines for Patients and their Physicians. Many patients have often said that physicians don't know much about cryoablation, and of course, patients have limited knowledge. So I wanted to create a document that they could share it with their docs to help them understand not only what cryoablation is, but how the other disciplines that treat breast cancer, medical oncology, radiation, radiology, et cetera, how they can relate and manage a patient who's been treated with or is thinking about cryoablation.
I also told some of the patients, maybe they should send a copy of that paper to their insurance companies when they're fighting them. To educate them.
Please do. It's available online by link, or they can download it as a PDF file. They can read it. It's a little long, so just make sure you have some paper in your printer. But it covers really the spectrum of care, which was the goal, so that whether you're the surgeon or the medical oncologist or the radiation oncologist or the patient, there is a story there for you. So I'm going to reference it at various times. We're not going to show any, images on screen, but I'll show you kind of where you can find relevant images. At least I'll try to show you where you can find relevant images in the paper, and you can download it later and take a look. So let's get started.
I've read it. What stages of breast cancer can be treated with cryoablation?
Thank you. Well, that's actually one of the first topics that I cover in the paper. There's actually a table on page 2, which talks about, it actually summarizes another paper that I presented and wrote previously that looked at the different categories that you can apply, where you can apply cryoablation. You could apply it in the traditional way, like kind of the standard way, which is a stage 1 breast cancer tumor that's small, node negative, kind of the ideal tumor for cryoablation. That's the one that most of the data currently support. But, there's a place for cryoablation potentially in all stages of breast cancer, from, stage 0, which we'll talk about, I think, to stage 4. And it could either serve as the definitive treatment, like we said in the stage 1 example, or even as a stopgap measure, like a treatment that you can apply to kill a tumor while you deal with other things that may be active in your life, like, or we call that as a stopgap measure. So you can look at the table, but the point is that you just really have to have a situation where you have a tumor that can be ablated either with 1 or more ablations to encompass the total lesion. And that can apply to stage 2, stage 3, and even stage 4 cancers.
But all in all, it's generally an individual case, and they have to just have their case reviewed to find out if they fit or not.
Yeah, that's what I usually advise. I mean, certainly I started off doing only cryoablation of very small tumors, and over the years that's evolved. It's basically I've been pushed along by patients to do larger and larger ones. So and more challenging ones in terms of their location and so forth. So I have, I've generally, now I think it's just generally best to take a look at the case to see what challenges, may be there. Certainly experience matters a lot. So I've had to sort of approach cryoablation through many different, angles and kind of find workarounds around certain challenges. So it's really a matter of just having the case reviewed and seeing if it counts. There's actually one other point that I was going to make, which is stage 4 breast cancer. Historically, we have considered stage 4 breast cancer to be a non-surgical disease, meaning that it can only be managed with medications, not with surgery. And that was partly based on the view that surgery has morbidity, harm, and it doesn't necessarily improve cancer survival for most people. It does for some patients. But the way that cryoablation fits in that is that, you can use cryoablation to kill the cancer in a way that prevents it from growing or becoming a source for more spread. And then, of course, you can do that with minimal morbidity. So the risk-benefit balance of harm versus benefit shifts in favor of treating in stage 4 disease as opposed to not treating the tumor site.
Doesn't matter where it is, like mine was in the liver afterwards.
Well, I mean, I only do breast cryoablation, so for me it matters where it is. But there are places in the world where other sites are ablated, whether it's in the liver or lung and so forth. So, cryoablation has a role. Other forms of ablation have a role for treating metastatic disease, as long as it's not disseminated. If it's in few sites, then it becomes a more manageable problem. If it's in more and more sites, then it becomes more of a challenge. But whether it's in the bone or solid organs, there's potentially the opportunity to treat those sites.
Oh,
for
even the
patient.
bone.
Yes,
Wow. You just have to find somebody that does it.
exactly.
Does it matter if it's a radiologist or a surgeon who performs cryoablation?
Well, I spent a few minutes talking about that in the paper, kind of at the beginning, because it's a little bit controversial, but I'll give you my perspective on it. And this is my opinion. It's an informed opinion, but it's my opinion, which is that, you know, as a breast cancer surgeon, we have a role of treating the entire, managing patient for the entire continuum of care. We work them up, we treat them, we make sure that they're referred to the proper other, specialists. Workup includes, counseling about cryoablation, but also the alternative surgery. It involves genetic testing, genomic testing, various other things that we'll talk about. All that happens, and then the patient is treated, presumably cryoablation, and then we manage the referral to medical oncology. We manage the referral to radiation oncology, and then provide ongoing follow-up. So the difference between the role of the surgeon and the role of the radiologist usually in breast cancer care is that radiologists basically intervene with imaging, or they do a treatment, but they don't provide the pre-treatment counseling and evaluation, and they don't routinely provide referrals and post-op follow-up or post-surgery follow-up, including exams. So the problem with, relying solely upon a radiologist who works in a very narrow way is that patients who get treatment with radiologists might not get all the things they need before and all the things they need after. And instead they're left to either not do it because they don't know about it or to figure it out on their own. So part of the paper is focused on discussing what you should expect. I call it the accountable provider. They need to be accountable for those other things, not just sticking a needle in a tumor and freezing it. That's the easy part for most cases. The hard part is the other
Figuring
stuff.
everything else out.
Yeah, and then I would add one other thing, which is that there's a checklist that's on page 4, which just kind of lists like literally a checklist. So you can go through to say, okay, for you as an individual, were these things done? Are these things being considered? Just to make sure that whether you're being seen by a surgeon or a radiation oncologist or radiologist, that they are giving you appropriate consideration for the things.
They're not
that
missing
matter.
anything.
They're not missing anything.
I was really pleased yesterday. A lady was telling me she had her cryo done by somebody else. It was a radiologist, but she said that that radiologist had a surgeon in attendance while she did it.
Exactly. And so what I say is I'm perfectly supportive of radiologists doing it when they're working collaboratively with an accountable provider. They may be the technician, but they need to work with a surgeon or a medical oncologist who's going to take responsibility for all those other things to which, the provider has to be accountable. Radiologists have expertise in ultrasound. Many surgeons don't. So that's why most surgeons don't do cryoablation. So you need to have, surgeon with ultrasound expertise who can provide accountable care, literally, or the radiologist with ultrasound expertise working with a surgeon or medical oncologist who's going to provide that accountable management of the healthcare.
Since cryoablation is typically performed using ultrasound, what role does mammography or MRI play?
Thank you. So that is discussed on page 5 and 6 of the paper. And, ultrasound is the primary tool that we use for cryoablation because, ultrasound allows the procedure generally to be performed in the office, not necessarily in the radiology department, performed in the physician's office. So it's more accessible, user-friendly in that way. But ultrasound does not reveal everything. I mean, you can have a tumor that has calcifications. Calcifications aren't generally seen by ultrasound, or they're seen poorly. And one of the examples that I give, you can have a mass that is kind of well defined, but extending away from that mass to the left or right, you could have calcifications, which indicate the disease extends beyond the mass. So you need to have more than just ultrasound to be sure that the ultrasound is telling you the whole story. You can have findings that are only detectable by MRI, like maybe very small, we call them satellites that extend out past the main tumor. If you're going to treat, you need them, whether it's with surgery or cryoablation, you need to see the problem multidimensionally so that you can plan a treatment that encompasses all aspects. So my general recommendation is to have mammograms performed, ultrasound performed, and breast MRI performed before treatment to get the best view. Now, I understand and respect that not every patient wants to do all those things. So in the informed consent process, you just have to acknowledge that there's trade-off, that, okay, I'll do it based upon this limited body of information, but you may be missing things that may matter. And if that's if that's the choice that you make regarding healthcare, then I have to respect that, but it has to be an informed decision.
How does that work out with, I know you did a video on YouTube about breast density. If it's really dense, is it going to see those calcifications?
That's an excellent question. So breast density is a problem for seeing masses on the mammogram, but it is not at all a problem with seeing calcifications. Calcifications stand out like stars on the dark sky. They're easy to find on the mammogram. And that's where mammogram performs best, because the earliest stage of breast cancer, which is stage 0 or DCIS as we call it, is often manifested as calcifications on a mammogram. And so when you treat breast cancer, you have to treat not only the mass, but you have to treat the calcifications, especially if they are outside of the mass, if they're an indication of disease developing over a broader area. So breast density is not at all a problem for calcifications. It is a problem for masses. That's where ultrasound and MRI have an edge.
Okay. How do you manage a patient who has never had a needle biopsy performed for a tissue diagnosis?
Well, obviously, you kind of need to have a tissue diagnosis to truly know, number one, that you have cancer, and number two, that the type of cancer you have. I mean, I had a patient who was seen just last week who had a breast mass, and it was an ovarian cancer. It was a metastatic lesion.
Oh, wow.
Right. It wasn't really a breast cancer. And so obviously your treatment would be informed by the type of cancer. Melanoma is actually a very common source of metastatic disease to the breast as well. It's one of the most common. Some people have lymphoma as well, which is obviously a different kind of cancer. So number one, you can have a non-breast cancer that develops in the breast, and knowing what it is matters. Number two, even with breast cancer, there are many types. You know, there's hormone receptor positive, there's hormone receptor negative, there's HER2 positive, and there's some other categories as well. And you can't know that without a tissue sample. So I know that many people are concerned that the needle biopsy itself might be the cause of distant spread. I actually wrote a paper that I submitted for publication. It's under review now, that talked about that. I looked at the literature that's been published for breast and non-breast. The data are somewhat different. And the take-home message, I have two take-home messages. One is that it does happen that when you biopsy a tumor, that some cells may escape, or at least may move away from the main tumor, like along the needle track. But when you look at all of the trials that have looked at the long-term outcome of patients that have had biopsies of different sizes, small needle, like fine needle and core biopsy, there's no difference in the survival rate of those patients. That, yeah, maybe some cells escape, like they might escape as you draw down the street, but that single event doesn't alter the patient's long-term outcome. So although it may happen, it doesn't impact survival. Number two, it also has minimal impact or no impact on local recurrence as well. That's what, multiple studies, this is different. It's not necessarily true for other cancers, but these are the data for breast cancer. So basically it's a safe procedure, certainly compared to the fact that you need to know what you're dealing with in order to treat it effectively. The second point is that there's some maneuvers that can be done at the time of biopsy to manage that risk. And that's actually the most important thing. So even if it happens rarely, for a patient who's anxious about it, or even for your average patient, you can minimize that risk. And one way that we minimize the risk is that at the time of the procedure, we inject lidocaine with an epinephrine solution, an epinephrine-containing lidocaine, which causes the blood vessels feeding the area to constrict. So there's no flow into and out of the area, which minimizes the potential for cells escaping. Number two, when you do cryoablation, you're also literally freezing everything in place, so nothing can escape, and you're freezing, you kill it before it has a chance to escape. And then, there is some potential for needle track seeding where the tumor cells can, back a little bit out of when the needle biopsy is done, some can trail out into the needle track. But we can also ablate the needle track as well. And in fact, that happens routinely with cryoablation, that at least a portion of the needle track is ablated. But if, you're tremendously interested in additional parts of the needle track can be ablated up to the skin. So for patients who's just refusing to move forward without, some kind of precautions, there are precautions you can make. And I included those in the paper, which I'll make available to you one day.
I think it's fascinating that, because when I had my liver biopsy, they told me they were mammary glands. So I didn't realize, like you're talking about, you could have a liver cancer end up in the breast or whatever, end up the opposite way. Mine actually went from the breast to the liver, but I never even thought about it. But the pathologist had written on it that they were mammary cells or whatever.
It's important for them to know that because there are many cancers that spread to the liver. So if someone has a liver mass, is it from the intestinal tract? Is it from the breast?
But that was the thing. I didn't know they could come from all these other places.
Well, they can. And so now you know that, not only breast cancer develops in the breast. It's like the liver can receive metastasis from other places. The breast can receive.
I guess for me, it's kind of a positive thing that it was the mammary and the liver was what it turned out to be.
Yeah, it kind of supports it. Yeah, a single diagnosis that was.
It's easier to treat when it's a single diagnosis.
Absolutely.
How do you manage DCIS with cryoablation?
So, most of the data virtually all of the data out there that has been published and presented regarding the use of cryoablation has focused on the use of cryoablation for masses, stage 1 generally, but they're masses, they're things that you can see by ultrasound. DCIS is pretty hard to see by ultrasound. Most of it's quite tiny. It presents as these calcium deposits, which generally don't show up on ultrasound. There's no real mass to target. Now, the irony is that, we feel like we can use cryoablation for an invasive cancer that can spread and potentially cause death, but we can't use it for non-invasive breast cancer that probably doesn't require or shouldn't require the same level of aggressive treatment as an invasive cancer. Yet we, at this point, generally only offer DCIS patients surgery as a treatment, as a definitive treatment. So I've been interested in utilizing cryoablation as a way of treating DCIS. This is an approach that's currently being used in a clinical trial. We're looking for people to enroll in the trial. The treatment's free. It's for patients with DCIS that's measured by imaging. That's 2 centimeters or smaller in size. It has to be that size. It has to be verified by mammogram, ultrasound, MRI to be less than 2 centimeters or 2 centimeters or smaller in size. But basically, the way that we make it a suitable target for cryoablation is that we arrange for patients to undergo a placement of an ultrasound visible marker at the site of the DCIS. The ultrasound visible marker or clip is something that we can see by ultrasound. So if we put the marker in the place where the DCIS is located, we can then target the marker and treat the DCIS in the process. And so whether you're based in LA or based across the country, if you've been diagnosed with DCIS and you have a small lesion under 2 centimeters or 2 centimeters smaller, you're eligible to come out to at least be evaluated. And then if you're selected, we preview the images. You could come out for the treatment, and the treatment happen locally, but you can return home to have your follow-up imaging done. And all we ask is for the patients to undergo imaging subsequently, and also undergo a needle biopsy of the cryoablation site 6 months post-ablation.
You can only have one lesion, though, correct?
One lesion, and
2 centimeters or less.
2 centimeters or less, based upon the extent of calcification.
Can you have had a previous cancer, or you have to have never had anything before?
That's right. You cannot have had a previous cancer in that breast before. The other breasts, okay. But not in that breast.
What's new in the world of cryoablation? Any upcoming clinical trials?
Well, the main one that I would mention is the one that the American Society of Breast Surgeons is working on. That's the one that I think will be more widely available. I know that we're currently conducting, the DCS cryo trial, which I just mentioned, for DCS measuring 2 centimeters or smaller. I'm aware of a trial that's beginning, I think, at Washington University for stage 1 breast cancers, but I think it's actually a cryoablation and resect trial. So it's not definitive cryoablation. They get cryoablation, but the tumors.
And then they have a lumpectomy
Yes.
afterwards.
And there's a second DCS trial that's being conducted, I think, out of Florida, but it is also an ablate and resect trial. So the patients have cryoablation, but they have to have the tumor removed to verify ablation. We're not in the trial that I'm conducting, we're not requiring removal of the tumor to verify that the cryoablation was effective, just a needle biopsy 6 months post-ablation.
What is genomic testing and how is it used for patients treated with cryoablation?
Right, so I discussed genomic testing somewhere in the publication. There it is, it's on page 11. So, you probably are more familiar with the term genetic testing, where we test a human to see if they carry certain mutations that might indicate certain health risks. Genomic testing is actually testing of a tumor's genes, just the tumor's genes, to see if we could predict behavior. In general, genomic testing are commercial tests that your doc can order. It's a test that's performed on the tumor that's already been biopsied, the sample that sits in the lab. And what they basically aim to do is to use the test to achieve 2 goals. Number one, to be prognostic, like tumors with these genes, what is their general behavior? How frequently do they occur? That's one question. So we use it as it's a prognostic test. And the second one is as a predictive test. For tumors of this characteristic, what is their response to treatment? Can we predict their response to treatment? Can we predict whether or not they benefit from adding chemotherapy, or if chemotherapy doesn't add any benefit to improving them? If maybe anti-estrogen therapy alone will be enough. So there's several, commercially available genomic tests for breast cancer, invasive breast cancer, and there are also a couple for DCIS. So if you have, breast cancer, I think it's important to have it. The genomic tests don't apply to triple negative and they don't apply to HER2 positives because they are high risk cancers by their definition. The data more clearly show what outcomes and also the treatments that benefit them. But it's the challenging one is really the hormone receptor positive HER2 negative breast cancer. The ones we frequently treated in the past, maybe because they were a little large in size, but the data have shown that many of those tumors don't require chemotherapy, even if they're big, even if they're node positive, many don't require chemotherapy, if they have a favorable genomic signature. On the flip side, there are some cancers that are quite small, but they have a high risk behavior based on their genomics. And even though they're very small and you might not involve the lymph nodes, we might still recommend chemotherapy because of this behavior that is revealed by the tumor genetics, which we call genomics.
How does genetic testing apply to cryoablation patients?
Genetic or genomic?
Genetic.
Well, I'm going to make that 2 questions.
Oh, because you just did the genomic, but
yeah, but
okay.
Actually, and there's another dimension that I didn't mention. So first, I'm going to ask the question: how does genomics reply to cryoablation patients? So the way that genomics applies is that even if someone opts to have cryoablation, they may very well still benefit from systemic therapy, whether that's anti-estrogen therapy or chemotherapy. I know many people who have cryoablation don't want to have certain things, but it helps to be informed about your risk. If you like you sis, so if you assume your risk is low, but the test shows that your risk is high, it might motivate the patient to do a little bit more, even if maybe they won't have chemotherapy, but at least that might get them to take anti-estrogen therapy, kind of a middle solution. On the other hand, many people have tremendous anxiety about their risk of recurrence, when in fact they may have a low-risk tumor, and might tell them that maybe they don't need to take 5 years of anti-estrogen therapy, maybe they can get by with 2 or a lower dose. So on the flip side, it could help people lower their anxiety about it by having that insight. The last part that I want to say about genomics is that, lymph node surgery is a standard way of staging breast cancer to assess, its prognosis, and also to remove microscopic tumor cells that might be in the lymph nodes. But not every patient, in my view, needs to have lymph node surgery. I mean, it's becoming pretty commonly viewed that the older the age of the patient, the less there is a need for lymph node surgery. But for younger people, it's still kind of the rule. But if the tumor has a low genomic risk based upon genomic testing, I think that's a patient that you could more reasonably conclude doesn't need to have lymph node surgery. They can just have their nodes monitored. On the other hand, if they have a high risk tumor, that's a patient who has a higher risk of having lymph node spread, who would be a better case for recommending a lymph node biopsy. So that's how genomics can help a patient kind of navigate the decision about, should I do lymph node surgery? Should I not? Does genomic testing, relieve me of the burden of that?
And what about genetic?
So genetic testing, as I mentioned, is testing to see if there is a risk of,
it's like BRCA gene or whatever.
Yeah, like to see if there's a risk, if there's a mutation that increases your lifetime risk of having either recurrence of breast cancer or other types of cancers that may be that might manifest. Like a BRCA1 mutation is a high risk of breast cancer and a high risk of ovarian cancer. So even if we're only talking about your breast cancer today, if your genetic testing shows that you're BRCA positive, we would need to counsel you and manage your risk of ovarian cancer.
But that doesn't apply to her too.
It doesn't. It simply applies to the fact that you have a cancer diagnosis. Now, there's certain principles, like some of us, and I've actually published on the topic of using universal genetic testing, where regardless of your age, regardless of your tumor type, that you should consider genetic testing, because, usually we have used these sort of like rules to see who was tested, but we missed a lot of people because they didn't fit the rules. They didn't have a family history. They weren't young. Yet when we tested them, we found that they had a relevant mutation. It might not have been a breast cancer related mutation. It might have been a colon cancer related mutation that was revealed. So that's why there's some feeling that, every patient diagnosed with breast cancer should have.
So even if you're HER2, you should.
Yes.
Or triple negative.
Anything. Any breast cancer type.
But will the insurance cover it?
Well, that's another question. But at least the evidence suggests that, we miss a lot of people, because basically the rules that were created were primarily written with two thoughts in mind. One was they were looking for things that increase your risk of BRCA1 or BRCA2, because they fit a certain pattern, breast and ovarian cancer, but there are other mutations that don't fit that pattern, might be breast and thyroid or breast and colon. And so the rules didn't apply to those others. They just applied for the broad. And so that's why, a lot of people weren't considered for testing, because they didn't have a family history of breast cancer or a family history of ovarian cancer. Secondly, genetic testing used to be very expensive. So like in the thousands of dollars for tests. So they had to have very stringent rules so that they weren't recommending these expensive tests. Now, most genetic tests are about $200, $250. So since they're much cheaper, and we now know that the initial rules were just too stringent, you can kind of open the door to more widespread testing, and, so that you can think about other kinds of cancers that might manifest in that patient.
Because see, I was under the impression if you were HER2, it wouldn't be hereditary.
It can be hereditary.
It can?
Yes.
I didn't know that.
Or it might not be a breast cancer risk that you have. You may have the breast cancer might be what we call sporadic, like it just happened out of chance. But genetic testing might show that you are a carrier of a mutation that increases your risk of colon cancer.
Well, because I have 3 daughters.
Well, they may want to know. So it not only affects, our surveillance or recommendations, what kind of surveillance you should have subsequently for your own personal health, but if you have relatives who would be impacted by it, they should know about the risk that you might have shared with them if you test positive. If you test you and you're negative, then at least they won't have that concern that they got that mutation from you. Might have gotten it from a dad, but not from you.
Wow. Never would have thought. That's true. So I should probably get it tested then, maybe.
I don't necessarily require or strongly encourage universal testing, but I am supportive of it, at least conceptually. It's just a matter of whether or not the patient, I mean, some patients don't want to know, they feel it's a burden. Yeah, I respect that limitation, but
Food for thought.
food for thought, yes. Something to talk with your accountable provider.
How soon should women undergo treatment after a cancer diagnosis?
Well, we're gonna actually, I'm gonna suggest that
You
we.
definitely don't want to do what I did. 2.5 years.
You know, 2.5 years, yes. So we're gonna actually talk about, I'm gonna suggest that we cover that the next webinar, because there's a lot of information that's not just breast cancer specific that we should talk about. But the answer to the question, very simply put, is that there's a lot of evidence now to show that a 60-day delay from needle biopsy to the first course of care, like surgery or chemotherapy, has a direct correlation with survival. And that the longer the time lapses between diagnosis and treatment, the greater the chance of tumor progression from early stage to later stage. And that directly impacts survival. So, we normally think for, heart attacks and strokes, that time matters. You need to get to treatment within a reasonable time frame before the condition gets worse and the risk of death increases. We haven't had that same level of concern. We've had a lot of anxiety about breast cancer, but we haven't had the same level of urgency as a healthcare system to get patients with a cancer diagnosis efficiently to some sort of care, whether it's surgery or cryoablation or some other care, to get them efficiently to care. So I've spent actually a lot of even more time on that than cryoablation, trying to making the case. We'll talk about it more in the next webinar.
Because when you think about it, the last webinar where you talked to, or one of them where you talked about the
story of the dandelion.
The dandelion. Yeah, it's like the time between finding out and those little seeds could be floating around like a dandelion.
Yes.
How do you treat tumors of different sizes?
So as you know, I usually kind of use the example of a walnut to indicate the volume that can be ablated with the typical single ablation treatment. When we treat a tumor, we usually freeze it twice. That combination of 2 freezes is an ablation. And usually the technology that we have now for breast cancer ablation allows you to ablate or kill about the volume of a walnut. That's about 3 by 4 centimeters. So that means that your tumor has to be, if you're using a single ablation, has to be small enough to fit within the volume of a walnut and also have some surrounding negative, uninvolved tissue, so you have a negative margin, a clear margin. So that's what we can do with a standard ablation. But that really only works for patients with stage 1 breast cancer, tumors that are 2 centimeters or less, or just about that. But for those that have larger tumors, either we've said, you can't have cryoablation, or we modify the technique by using multiple overlapping ablations.
Kind of like a Venn diagram.
Yes.
That's what it reminded me of.
So I talk about that kind of on page 15 of the paper, where I show that you can use multiple overlapping ablations. They can't be edge to edge, or there'll be things that are missed.
They gotta overlap.
Yeah, they have to overlap. And so, developing kind of the technique and understanding of how much overlap is needed is something that, has taken me, 20 years to perfect, because there are no rules about it. So I'm developing the rules. But the take-home message is that it has to be a lot of overlap so that you're not missing skip areas between adjacent ablation zones. But in theory, you can use as many ablations as you need to cover an area. It might become, cost prohibitive, time prohibitive, but we know from ablation of other organs, whether it's in the liver or other sites, that you can do fairly large ablations of large tumors if you do enough overlaps. For breast cancer, most of the technology that we use now only allow ablation of one site at a time, where you put in one probe and you ablate one site. There's some technologies that allow you to put in 2 or 3 or 4 or 5 or 6 probes to ablate a large area in a single treatment. For breast cancer, since the technology for the most part is just a single probe system, we basically use serial ablation. So we'll ablate this area, then we'll immediately ablate the next one, and then immediately ablate the next one, and then immediately ablate the next one to cover the entire area.
You might be there all day.
I have been all day
I know.
for some patients.
I know, I've talked to them. Can you cryoablate lymph nodes?
Yes, we also cover that in the paper. So, traditionally, lymph node management has been, surgical removal, either with a lymph node biopsy or lymph node resection, because there's no body of data to say that, cryoablation is a suitable option. So we're basically innovating that approach. For the most part, for those that refuse lymph node surgery, if you have a suspicious node that looks grossly abnormal by ultrasound, that node can be targeted with ablation, just like the breast is targeted for ablation. There's some considerations that must be given to cryoablation of nodes. Number one, the location of the node matters. The axilla, which is where the breast nodes generally are located, it starts fairly low down at the breast, say maybe like about on the right side, about the 9 o'clock position, and it goes as high as the axillary vein, which is right below the clavicle. So nodes that are low down near the side of the breast or in the lower axilla can be easily targeted, but the higher the node, the greater the risk, because of the large vessels and nerves in an area, but also because that area is pretty warm. There's a lot of blood flow that's flowing through the large vessels to the arm. So there's some concern you might not be able to freeze an area cold enough to ablate the node successfully and safely. So if it's a very high node, I think surgery is actually better. If it's a low node, then I think cryoablation works well. The second point is that when you have one grossly abnormal node, there's a reasonable chance you have several other nodes that at the time of the treatment still look normal, but in 6 or 12 months without additional therapy, the tumor cells may grow and those nodes will become abnormal. So even though we may target one node, there still needs to be a game plan for how do you manage the neighboring nodes that are at risk of turning abnormal because the cancerous cells within them will grow. They can be managed with the addition of radiation to treat those nodes, and or the addition of medication, like anti-estrogen medication is a way of managing, microscopic cells that may be in those other nodes. It's not just focusing on the gross abnormal node. There has to be a game plan for the others.
Oh, I guess you could, pretty much. When is lymph node surgery recommended? I think you just covered that pretty much.
Well, so the question is, when is lymph node surgery recommended? I recommend it when it's a high node. When there are multiple nodes, you can't, the more tissue you ablate, the more collateral damage you can have, because there are also lymphatic vessels. So the more volume you ablate, the greater risk there's lymphedema. There's more discomfort with cryoablation of a large area in the abnormal area. And of course, as I said, you have to kind of avoid the large vessels. So the more complex the extent of disease, the greater the need for surgical management, because it can manage certain risks that you can't manage with cryoablation.
But you can still have cryoablation and then have the surgery for the lymph nodes, or have the surgery for lymph nodes prior to cryoablation.
Oh yeah, so you raised a good point. So you're talking, so I think you're giving an example of someone.
If you have a tumor and you have some lymph nodes, you can have the lymph nodes done surgically and the tumor done cryo.
Yeah, I mean, you have to sort of make a decision about what's important. Obviously, if your lymph nodes can't be managed with cryoablation, I would advocate managing them with surgery. And then, since a patient will be going to surgery, I'd say, well, if I'm going to surgery, you can certainly have your breasts treated with surgery as well. Now, that would be kind of the typical way of doing it.
But then you lose some volume if you do it that way.
Well, yeah, so that's and so
So-
that's a trade-off. So you say, well, but when we remove tissue with surgery, there are some cosmetic impacts, volume, shape, and so forth. So a patient can conclude that I would rather have cryoablation of my breast because it has minimal long-term change in the breast shape and volume from a cosmetic perspective. But since my lymph nodes can't be managed with cryoablation, I'm willing to have surgery of the lymph nodes. So in that case, you can do it in any order. You can do the lymph node surgery first. You can do the cryoablation at first. You can do the cryoablation, say with me, and do the lymph node surgery at home with your doc. Before or after. So they don't have to happen at the same time by the same surgeon. You can separate them.
But there are cases where you've done one day and the other the next day.
Yes. When I am the provider for both procedures, I'm a surgeon, so I do surgery quite regularly. Then we'll usually sequence it just for the patient's convenience in consecutive days, where we do cryoablation in the office one day, we do lymph node surgery in the operating room the next day, in either order.
Is sentinel node biopsy, if sentinel node biopsy is needed, do you schedule it before or after cryoablation? Well, I think you just answered that.
I did, but I didn't.
Yeah.
So an example that we just talked about, we talked about a patient with positive nodes that needed the nodes removed surgically. And so it didn't really matter the order. But if the patient has a negative axilla, meaning if their lymph nodes look normal, and we have to use sentinel node mapping
Oh, you need to do
find
it
the
before.
nodes, you might have to do it before. The reason, and I talk about that in the paper on page 18.
Because of the tracer, I'm
The
guessing.
tracer, and it's not, and it's the tracer, but it's also that there is actually a bundle of lymphatic vessels that travel from the nipple area to the armpit on both sides. And it tends to follow on the right side along the 10 o'clock axis, on the left side along the 2 o'clock axis, right below the skin surface. So when we do a sentinel biopsy procedure, we usually inject blue dye or radioactive substance in the breast. It's then taken up in a lymphatic drainage. It courses through those vessels towards the lymph nodes, and then we find the lymph node and remove the lymph node. The problem is if you do surgery or ablation near the skin along the path of that lymphatic vessel, it's possible you might disrupt the drainage and make it hard for the tracer to accurately find the right node. So if the tumor is in one of those locations and the patient plans to do a lymph node biopsy, in that case, I would recommend doing either the tracer injection or at least the tracer injection or the surgery before cryoablation. However, if it's in another location, like not along the main pathways of lymphatics, it doesn't really matter which sequence you're doing it. So, but it's important, like if you're having, these are things that a surgeon would think about. But if you're having cryoablation with a radiologist who doesn't necessarily understand the implications of the ablation and how it can compromise a lymph node procedure, then that's where you may miss out on something that's important, where you may burn a bridge that you can't cross again. So the location matters, how close to the skin matters, and if lymph node surgery is to be performed or considered, the timing has to be right.
So when you do the tracer, you'll take some kind of a film so that after the cryo, you know where you need to go.
So the two common strategies for tracers is that we use a blue dye tracer, which moves pretty quickly, and washes out of the nodes fairly quickly. Like it's there for maybe a half day and then it's gone, or at least it's not there for days or 2 or 3 days. The radioactive tracer tends to linger in the nodes a little bit longer. So whichever one you use, the idea is to inject the tracer and get it to the lymph nodes before you do the ablation. So I didn't necessarily say, I didn't want to imply that the surgery had to be done first, although it can be done first, but the tracer has to be done first so that the tracer can travel to the node before the ablation. So for example, she might have the tracer injection today in the morning, cryoablation in the afternoon, and then surgery the next day. Because between the injection of the tracer and the cryoablation procedure, that 2 or 3 hour period, for example, the tracer would have traveled to the nodes that would make that, make it no longer an issue if I ablate the pathway, because it already would have moved to the lymph node.
Why is radiation sometimes recommended after cryo?
Well, I'm just going to give you the example, starting with the example of surgery. So when we do surgery, where we presumably cut the tumor out and get clear margins, we know from history and from the use of for multiple trials that patients have still a moderately high risk of recurrence in the site. And that's because often there are other spots of disease that's too small to detect, that's present around the main tumor, and that without additional treatment of a broader area around the cancer, those seeds sprout and grow. And so because of that, the general rule is for patients with treated lumpectomy, that they would be followed by radiation. This is for people that have had surgery who we believe have clear margins because we've done surgery. Now I'm using believe because margin assessment is a very incomplete process, but still, that's the kind of the gold standard. Well, when we have cryoablation, the same challenges exist. I might see a well-defined tumor by mammogram, ultrasound, MRI, all of them, but there's a possibility that there are other tumor foci beyond that main area that are microscopic and can't be seen. We try to manage it first by ablating a wide margin to get those that are maybe just a little bit past the edges of the tumor, but there may be some that are a little bit past that. And so, in many instances, we recommend radiation for patients, especially those with higher risk tumors. Now, we know in both groups, for people that are having surgery or having cryoablation, that there are low risk cases where the risk of having additional disease is more manageable, or the risk of having a recurrence is lower. The lowest hanging fruit, or the most obvious group, are women over the age of 70. You can make a very strong case that those women don't need any radiation at all, as long as they have a stage 1 tumor that's estrogen sensitive that you can manage with anti-estrogen therapy. Younger people or people with non-estrogen receptor positive tumors, that don't have like a long-term pill that they can take, have a greater need for radiation. They benefit more because we don't have these other ways of managing those little seeds that might exist around the main tumor.
What are anti-cancer medications needed for after cryoablation?
Well, I just mentioned one, that is we take, we recommend like endocrine therapy, or we call anti-estrogen therapy, tamoxifen and anastrozole and those types of medications, letrozole, exemestane. Those medications are given with several goals. The most immediate one for the cryoablation site is to reduce the risk of recurrence of residual tumor cells around the cryoablation site. If there are microscopic tumors in the lymph nodes, it also reduces the risk of those cells progressing. So that's the most immediate. But the more important goal gets back to that dandelion example, that, in the time that a tumor has had to grow in the breast, which is usually years before it's diagnosed, tumor cells escape. Now, to be frank, unfortunately, the vast majority of tumor cells that escape from the tumor don't have the ability to go someplace and survive, and so they
don't root.
They don't root, and they're not consequential. But some percentage of them is, and the bigger the tumor or the longer the time lapse, the greater chance that there'll be some that find the right soil to root in and grow. And even though they may not be apparent when you're treated or a year after you treat it, in 2 or 3 years, those seeds might root and may grow. And that's kind of the story of the dandelion, which is that, you may pull up the dandelion and it might be not next summer, but the next summer that the seed sprouts. And so the reason for systemic therapy is based on the assumption that there are seeds that sprout that you are unaware of at the time of the cancer treatment. You can do PET scans, you can do CAT scans, you can do all the scans in the world. You can't see, it's just not possible to see, using microscopic or a seed that hasn't sprouted yet. You can detect them once it's a pile of 1,000 seeds, because it's big enough to be seen on the, a cluster of 1,000 cells, big enough to be seen on a scan, but you can't see individual seeds or cancer cells on a scan. So we know bigger tumor, higher grade tumors have a higher risk of spread, have a higher risk of recurrence. We think, for everyone, they should consider the pros and cons of systemic therapy for that reason.
Are there special challenges with cryoablation of the triple negative and the HER2 breast cancers?
Well, number one is that they're not really well treated with anti-estrogen therapy. You can treat some HER2 positive breast cancers with anti-estrogen therapy, but the main driver for its growth is the HER2 part, not the ER or PR part. And then for triple negative breast cancers, there is no anti-estrogen therapy or pill therapy that we can give to treat it or prevent it from recurring. So that's the first challenge. They limit the options. So that means that, at least for triple negative, chemotherapy has to be part would be recommended as part of the story.
Now they're actually doing studies though to see if it can, some of the triple negative is low HER2. It has like slightly got some, just enough to use it as a Trojan horse.
Yeah, so that they mean ER negative doesn't mean that HER2 negative doesn't mean that there is no HER2 expression. It means that it's kind of a normal amount, not an amplified amount like we call the HER2 positives. But yeah, there may be an opportunity to use, anti-HER2 therapy for some triple negatives. But that still is optimally given with chemotherapy as part of the story. And for HER2 positive breast cancers, we have, of course, the need to add anti-HER2 therapy, which works best when combined with chemotherapy. So the drug therapy options change. There's also recognition that the sequencing of therapy may need to be changed, that there is a body of evidence that shows that for people with stage 2 and higher triple negative or HER2 positive breast cancers, that they have better long-term outcomes if we treat with chemotherapy first or drug therapy first and do surgery later. The same principle would apply to cryoablation, at least in theory, that there's probably an advantage to treating with the drug therapy first, followed by the procedure later. There are two reasons for that. Number one, when you pre-treat the tumor with chemotherapy or anti-HER2 therapy first, you get to see how well it responds. And if it responds brilliantly, then it tells you that the treatment's effective, you continue on with it. If it doesn't respond, it tells you that you may need to change. And you can do that after 1 or 2 cycles. Secondly, for those that have pre-treatment and then undergo surgery or a biopsy prior to cryoablation, we can tell if there's any surviving tumor left. Those that have no surviving tumor have the best prognosis, and obviously that would be a great thing. Those that still have surviving tumor have a compromise of their prognosis that could be improved by adding additional therapy. So it allows us to find the complete responders or the incomplete responders, and then have the ability to recommend to the incomplete responders additional therapy to improve their long-term response.
If a person had chemotherapy prior to cryoablation, are there any special precautions taken to cryoablate their cancers?
Yeah, so there is a challenge, although there's clearly a sort of a systemic therapy benefit to giving, and potentially a survival benefit to giving chemotherapy or anti-therapy up front. It becomes a challenge when you want to treat that patient with cryoablation, because hopefully you've gotten a good response. The tumor is shrunk and maybe it's not so easily seen now. That'd be a good outcome for the patient, but a challenging thing for cryoablation. So we have to take certain precautions. The main precaution that I take is that I don't assume that since the tumor has shrunk from here to here, that there's no disease left in the wake. It's like sometimes when the tide goes out on the ocean, sometimes there are little puddles of water left on the beach. We have to anticipate that when the tumor shrinks, that there may be some little puddles of tumor cells left in the wake. So my rule is to ablate the original volume, not just the final volume, to get that confidence that we're not leaving untreated disease. The second precaution is that when the tumor shrinks, you may not exactly know where the original edges were. So if a patient if I see someone before they start drug therapy or near the beginning, I would recommend that they undergo placement of a couple of different additional markers, one at one edge and one at the other edge of the mass, so that those markers can remain as a signpost for kind of the span of disease. So at the time of cryoablation, I would then treat that original span of disease so that I'm not sort of guessing when the patient presents for cryoablation.
What's the abscopal effect?
You got it. Abscopal effect. So the abscopal effect is the concept that if you treat tumor at one site, that treatment will induce an immune benefit that prevents tumors from growing or causes tumor regression at a distant site. The typical example that we would think about is, say, if there's a metastasis in the liver, even if you don't know about it, maybe it's tiny, if you treat this breast cancer site with cryoablation or radiation, that will produce an immune response that prevents that tumor cell in the liver from growing or causes the tumor to shrink. And so there is a lot of interest in, the potential for an abscopal effect with patients treated with cryoablation. It's been seen in animal studies, quite a number of animal studies, but animal studies are pretty controlled experiments where you can control so many factors that you can't control in human. Unfortunately, it's not so clear that it is clear that the abscopal effect doesn't happen to the same extent in humans. It also is clear that it probably needs a little bit of a nudge with maybe certain other agents to enhance the effect. The last thing that is clear is that, it's like if it happens, it's likely going to happen in triple negative and HER2 positive breast cancers, because those cancers are naturally immunogenic. They already are inclined to stimulate the immune system. Some of the ways that tumors engage the immune system is that they prevent the immune system from responding. So if you can both ablate and give drugs to enhance the effect, then those are the ones that are most likely to be responsive. Currently, there is a clinical trial that's ongoing looking at cryoablation for patients with triple negative breast cancers, and there are some survival benefits that are being seen in those patients. So that abscopal effect is happening there.
Didn't happen for me.
Well, none of the treatments are perfect.
I mean, maybe I needed something to boost it.
Or needed it earlier.
Yeah. Or you needed, earlier, definitely.
But those, in fact, the other thing is the design of the trial is that the patient has to be treated with chemotherapy first, and then they get cryoablation with additional immunotherapy after.
So the chemo might make a difference.
Right. So, the inclusion criteria is people that had residual disease after chemo would then have cryoablation plus additional drugs. So that's an example of how pre-treatment with chemotherapy can help identify the poor responders or the incomplete responders who would then be treated with immunotherapy and with cryoablation. Now, I know that there are quite a number of people around the globe that are injecting immunotherapy in tumors based upon the concept that it can work. There's really no evidence that is effective for non-triple negative breast cancers. And even in triple negatives, it's a trial that's ongoing. So we need to sort of see what that trial shows. My view, and I talk about that, is to caution people not to agree. I mean, it's a nice concept, but there are also risks with these drugs as well. And so, it's I don't think that it's prudent to use it, especially in situations when we don't have any evidence that it works in humans for most cancers. Immunotherapy with cryoablation, certainly not a single dose and then even in the trial of triple negatives, they get a series of doses, both before cryoablation and after cryoablation.
What imaging follow-up is recommended for patients treated with cryoablation?
Well, there are no rules, but I propose some strategies in the paper. My own policy is to recommend that patients undergo post-cryoablation imaging 6 months after, and then 12 months after, and then continue with yearly imaging as they would do it in the normal circumstances, beginning at 1 year. At the 6-month time point, I recommend mammograms, ultrasound, MRI, and needle biopsy of the cryoablation site. They're not required to have those things, but the case that I make is that, at least with respect to the tumor that's ablated, no imaging can tell you that the tumor is not alive, because what we're looking for is if there's any microscopic surviving cells, and you just can't tell that from imaging if they're microscopic. So since there's some anxiety and uncertainty about how successful cryoablation is, and people have to go back to their doctors who would worry whether or not it worked, I think, you can put the matter to rest by doing a needle biopsy of the site to prove that even though you can feel a lump there still, and there's something there on the imaging, it's a dead scar, it's a healing scar, it's not surviving cancer cells. That's the first goal. The second is, when we do cryoablation, we focus on the tumor and a rim of tissue around it, but the place that's at greatest risk of recurrence is just beyond the cryoablation site, the area that you didn't treat. Just like patients that have lumpectomy, it's the part you left behind is that is the site of recurrence. So the imaging, whether it's by mammography, ultrasound, MRI, allows us to look around the edges of the cryoablation site much closer to get some confidence that there's no sign of recurrence. And if there is, then to do the appropriate biopsy around the cryoablation site to rule out a recurrence.
What is a tumor ghost?
So that's exactly one of the things that it took me some time to become comfortable with. So when you ablate a tumor, say you have a 2 centimeter tumor in the breast, and you ablate it, the cells are killed, but that 2 centimeter mass remains. And we call it a tumor ghost because it's a remnant of a dead tumor, but it shows up on the mammogram, it shows up on MRI, it shows up on ultrasound, at least early on. And so at 6, 12, 18 months, when they do imaging, their first thought was, I can still see the tumor. What they're looking at is a tumor ghost. It's a tumor ghost because hopefully, perhaps the patient had a biopsy of it at 6 months and we already proved it's a dead tumor. So they're just seeing kind of the bits that remain as the body is absorbing it. The tumor ghost gradually goes away, but for a while, it is there, it is seen, and it's what complicates the post-imaging interpretation. So number one, it's important to have, someone with experience looking at the post-cryoablation imaging study, so they don't overreact to it because they'll still see mass. Secondly, there's often comments made that, oh, look, the tumor has grown because although the tumor was only 2 centimeters, we ablated the size of a walnut, and now they see a walnut on the mammogram and say, oh, it's doubled in size, when it's actually just a treatment zone surrounding it, in the center of which is the tumor ghost. So it's something to know about. I write about it. I show some examples of it in the paper so that radiologists, when you share this paper with a radiologist, they'll become familiar with what they should expect to see, at various time points at the cryoablation.
I know I like to look at all my scans myself. And to me on the MRI, it looked like smashed glass.
So smashed
Or like
glass,
snow or something,
right? So what you're describing, I think, is the appearance that calcifications may have or can have on mammogram.
Well, I saw it on the MRI.
Okay, so let me just address the mammogram manifestation first. Someone may have calcifications because their tumor had calcifications originally, and so we're still, the tumor calcifications persist. They're like petrified dead cancer cells. They don't get absorbed, like stone doesn't get absorbed. But when we do a biopsy, we prove that it's dead, calcium. And so, those things remain on the mammogram and may be detectable going forward. Secondly, fat necrosis is a phenomenon that happens when we ablate fatty tissue. Fat dies, as we expect it to, but when fat dies, it often collects calcium. And so sometimes people have an increased number of calcium deposits because of fat necrosis. Now, fortunately, these calcifications look different than cancer calcifications. So usually we feel pretty confident that, okay, that's just artifact from the procedure. It's not more cancer forming, but it's something that someone might see that needs to be managed. Radiologist has to at least have an understanding of that. We see it after surgery, we see it after cryoablation. Now, on MRI, there's also artifacts that appears. It's artifact of the treatment. Fat necrosis also can appear on an MRI, and it tends to show up and be quite prominent, like maybe, snow or crushed stone or crushed glass. So the radiologist who's looking at the MRI has to have experience with recognizing fat necrosis on MRI. Fortunately, it has different physiology, different imaging presentations. There's ways that they can tune the image to make fat necrosis become more obvious. Like they can have more confidence that, yes, that's fat necrosis versus, no, this is the beginning of a cancer recurrence. But like many things, it's a matter of experience. And, hats off to the radiologists that have that experience. We've been working with people for many years, upwards of 20 years, who have experience with cryoablation. There are radiologists around the country who have that experience. And some, provide independent reads. So even if you at home don't have a radiologist with that level of experience, you can, send your studies to a radiologist who could provide a second read of the imaging studies.
And I came across one recently, so if somebody needs one, they can just message me.
Great.
Can cryoablation be used to ablate lesions for stage 4 breast cancer patients or just early stage? For example, subcutaneous breast nodules in an area that has previously been irradiated, so radiation is not an option.
So I discussed the first part of the question earlier when I talked about it. We talk about it in the paper with different stages that can be. There's an additional consideration here, which is that this person apparently has a recurrence as a subcutaneous nodule in an area that has previously been irradiated and can't be irradiated again. So the subcutaneous nodule means a tumor deposit under the skin. And as long as it's under the skin and not extending into the skin, then we can basically manage it as a new tumor, one that you can, separate from the skin with some injection of saline and then ablate as an independent tumor. So that's not at all a problem to ablate. The challenge is, if it's a tumor that is also going into the skin, that can't be separated from the skin. And so that kind of tumor might best be treated with just excision of the affected skin and closure of the wound. So if it's independent from the skin, subcutaneous, that's what subcutaneous means, then it can be ablated. If it's intradermal or extends into the skin, like subcutaneous with the part that grows into the skin, then that can't be treated effectively with cryoablation without killing the skin. In that case, it would make most sense just to excise that part with surgery.
How does cryoablation impact future node biopsies? Does it prevent the use of dye tracers to test for reoccurrence?
We talked about that, so I'm going to refer the patient to the paper. Has to do with tumor location, and if it's in the 10 to 12 o'clock position of the right or left breast, you just have to time it appropriately.
If you have a positive sentinel nodes that are removed, can you still have cryoablation? Well, we already pretty much talked about that one.
Yes. Previous lymph node surgery doesn't prevent you from having cryoablation.
Do success rates of the procedure decrease with node involvement?
Yeah, we touched upon that, and I talk about it in the paper as well. It's that you just can't think about only the lymph node that looks abnormal. You have to have some amount of worry about the remaining lymph nodes, because even though they look normal, they might not be normal microscopically. And since they're being left behind without additional therapy, they may be the source of further tumor growth. So taking systemic therapy as a way of managing that risk, And ideally, also adding radiation therapy is a great way to reduce the risk of recurrence without adding the risk of lymphedema.
What's your reaction to breast surgeons who say that over 1.5 centimeters is risky because it could be missed?
I think they should read the paper. All of their
This
answers
person
right
had a
there.
2.9 centimeter one.
Right, so, it can be treated with multiple ablations. For 2.9 centimeters, it pushes the limit of the walnut limit. So
probably
I
be
think it
two.
would be best treated with two, for you to have both a treatment and a margin around it. For things that are possibly missed, of course, there may be satellites around the main tumor. A wider margin helps. If it's a higher risk tumor based upon the patient's age or the tumor characteristics, adding radiation therapy is given to manage risk, just like they do with lumpectomy. Adding medication also would help to manage that risk, just like they do with lumpectomy. It's the same concept.
Have there been successful cases with fibroepithelial lesions?
Fibroepithelial lesion. So fibroepithelial means that it's like most cancers are like epithelial. It's mostly cancer cells, not much collagen or non-cellular material. And that's what the fibro part. Not much fibrous material. Most cancer cells are mostly cells, not much fiber. Fibroepithelial lesion is the reverse. These are benign lesions. They're mostly fibrous tissue with occasional cells. And a fibroadenoma, which is a very common breast mass, is a fibroepithelial lesion. But there are also some kind of a little bit more aggressive fibroepithelial lesions called, say, a Phyllodes tumor is one. Either can be managed with cryoablation. It's just a matter of having a good target and ablating a margin. A margin is especially important for a Phyllodes tumor, which has a higher risk of recurrence. Not so important for fibroadenoma, but either can be treated with cryoablation.
Is cryoablation possible after mastectomy, reconstruction, and radiation, if there happen to be a reoccurrence?
So I think you bring out a very good point, first of all, that recurrences are possible after cryoablation. That's all right. And
After
just,
mastectomy,
well,
yeah.
it's possible after cryoablation.
Right.
It's possible after lumpectomy. It's possible after mastectomy. None of the procedures, give you a zero risk of having a recurrence. And so, sometimes patients choose a lumpectomy choose a mastectomy because they think that's going to give them that assurance of no recurrence. It doesn't. Higher risk tumors have a higher chance of recurrence after mastectomy. No positive tumors have a higher risk of recurrence in the breast tissue after mastectomy. The second principle is when mastectomy is done, there is normally some breast tissue left behind, and that breast tissue can be the source of recurrence. Fortunately, it's low enough that we don't recommend mammograms for patients that have mastectomy, but exams and should be done just to see if there's any subcutaneous nodules that are developing under the skin. If someone has a nodule that forms under the skin after mastectomy, and if it doesn't grow into the skin, then that can be very easily managed with cryoablation, just like the example that I gave before.
Do you think surgeons hesitate to learn and do cryoablation because they need to master reading ultrasound? Seems like that would be a whole bunch more education.
It is. And so, the American Society of Breast Surgeons has taken on that challenge. I mean, for years, they've been educating surgeons about how to do ultrasound-guided procedures, whether it's for biopsies or breast exams, and now cryoablation. So part of this effort that I mentioned of them sort of taking on this, cryoablation is that for 2 decades almost, they've been teaching surgeons how to do ultrasound. This is simply an application of that. They have a credentialing program. I am a graduate of that program where, surgeons are taught ultrasound. We have to go through testing. We have to present cases, just like radiologists do to get certified to do ultrasound. The surgeons are put through the same rigor and they get accredited. So the society, supports accreditation of surgeons so that they are as skilled as a radiologist to perform ultrasound guided procedures. And that includes interpretation of imaging, and includes, cryoablation and biopsies and so forth. Yes.
But do you think that surgeons that don't do it because they don't want to do all that?
Well, my opinion is surgeons who don't want to do all that should not do cryoablation. Because,
Well, no, obviously they shouldn't,
they
but
should,
I guess it was
And-
just the idea of, is it because they don't want to do it, that they probably don't want to do cryoablation? Because they don't want to have to go the extra step to.
it is not easy. I mean, the course is rigorous. And so the rigor of the course itself is a barrier to surgeons becoming certified to do so. And but that's okay. I mean, this is, crucially, I mean, just as they're skilled, they spent years being trained to do breast surgery. That's why they are empowered to do that. This is not something that they can just pick up and do with the same level of skill. They need to have the skills, they need to develop the skills, and so it's okay that it's rigorous. It should be those that are willing to go through the rigor of the training that are allowed to do cryoablation.
Sure. Should a HER2 positive patient do Herceptin prior to cryoablation?
Yes, but if the best outcomes with pre-treatment before cryoablation is for people that do anti-HER2 therapy combined with chemotherapy. Because that's where the data show that sequencing drug therapy first has survival implications and where the response is likely to be best. If the patient is not willing to do the chemotherapy and HER2 therapy combined, then I think it's best if they go forward with the cryoablation first. The reason is the following. Although the HER2 therapy will work if it's given alone, it'll work much less and it'll take longer for it to work. And so the longer the tumor is there present in the breast, and the bigger it is, the more opportunities there will be for metastasis. So if you're not going to give the best chance for a quick response, it's best to kill the tumor and then use the anti-HER2 therapy to get the things that might have already left the breast, not to give it to shrink the tumor, because it's going to be a lot less effective in doing that in a quick way. So if it's combined therapy, chemotherapy and HER2 therapy, then that's clearly the best approach. If it's HER2 therapy alone, I think it's best to do cryo first, followed by the HER2 therapy.
How do you know when to stop HER2 therapy?
Well, there are principles. I mean, the data that we, the kind of the evidence approach is that it's a year-long for patients with, non-metastatic disease, it's a year-long course. Or maybe it's a 6-month course for the patients with smaller, no negative tumors. If someone is doing HER2 upfront, HER2 alone, I mean, Herceptin alone, there is no data for how long you treat it for a patient with non-metastatic disease. You don't really know when to stop, and so you end up being on a very long time without getting the great response. And then you still may have to do the same extent of surgery or the same extent of cryoablation that you did originally.
See, I wonder if my mistake was not doing it for longer. I did it afterwards, but I only did it for 6 months. Maybe I should have done it for a year. It's hard to know.
It's hard to know, but that was not the scenario you gave. There's still some,
just throwing that out there.
Some debate about how long you need to give it, or at least it's still an uncertain question about how long you have to give it after. But if you're giving it before, there's a pretty standard regimen. You give a 6-cycle course of the TCHP, and then you do intervention, surgery, or cryoablation. That's a fairly established regimen. Or there are other regimens, but they're fairly established rules about what you give before you do surgery, or in this case, cryoablation. What you do after, especially with higher stage disease, there's a little bit more flexibility there.
Is it best to have a mammogram close to the cryo procedure to ensure the markers haven't migrated? Because I know you talk about migrating to markers too.
Right. So marker migration is a problem, but it's first of all, it's primarily a problem for people that have ultrasound visible tumors. If you're using, say, ultrasound to perform cryoablation, you see the tumor. So the marker migration doesn't really matter so much.
But what about with DCIS?
But with non-ultrasound visible tumors or small invasive cancers that are hard to see by ultrasound because they're small, they're like just detectable, or DCIS, which has no ultrasound visible part, is that, if you're using the marker as the target, the marker has to be in the center of the thing you're targeting. And what happens actually right after the biopsy, not right before the procedure, is that, the marker might migrate away from the tumor. It happens because, particularly when we do mammogram guided biopsies, the breast is compressed, and then we put the marker in, and the breast relaxes.
Oh,
The marker doesn't always stay exactly like accordion. You don't know which part of the accordion is going to end up when the breast relaxes. And in fact, marker migration of a centimeter or so is common. It happens in 20 to 30% of patients. If your tumor is small and the marker is a centimeter away, and you target a marker, you miss the tumor. Right.
Yeah.
The other thing is that there's often a little bleeding that happens after the biopsy. And so even though the marker is placed, perfectly within the center of the tumor, the bleeding or clot might push the marker a little bit to the left or right of the tumor. It might push it out of the tumor. And so again, you need to know. So one way that we assess marker migration is that, if you've had a breast biopsy before, radiologists normally do a mammogram right after the biopsy to make sure that the marker that they put in to document the tumor site is still in the intended place. They do it right after the biopsy to verify or assess the degree of migration. If there's migration, ideally they would say the marker migrated 2 centimeters to the left of the tumor, so that the person treating the downstream can know that I should aim 2 centimeters to the right of the marker because it migrated. Or ideally they'll say the marker is exactly where we intended it to be.
Can it migrate later or no?
It's not likely to migrate later because things starts to scar. The clot solidifies, scar, and so wherever it ends up, it is in its final destination within a day. After a day, it's not going to move. I mean, I never say never, but it's likely not going to move. But for that reason, there's no need to do another mammogram closer to surgery to verify that there's no migration, because that migration happens pretty quickly after the biopsy, not days or weeks or months later.
Okay. That's all my questions I have.
I think we covered it all with a couple of minutes to spare.
Yeah, got about 3 minutes.
So we may not use them all, but I do want to emphasize that a lot of the things, in fact, virtually all the things that we talked about are in this manuscript that is available online, Breast Cancer Cryoablation in the Multidisciplinary Setting. You see how we dealt with the other disciplines, the implications for radiology in medical oncology and radiation oncology.
I think it's a really good paper for sending to your insurance company or to your primary carers or whoever. Like I have ladies that come and say, oh, the surgeon I'm seeing told me it doesn't work, or it doesn't this or that, I think they should I tell them, I said, give them the paper, give them the link, tell them to go read it.
Well, we're there are a lot of us that are doing our best to educate the community, the medical community at large about cryoablation. We do it at national meetings. Obviously, we do it through publications. But, your docs are busy, and it's kind of hard for them to keep up with the reading that they, need to do. Sometimes they're not open to willing to open their minds to other things. So they have to be nudged. Like I've been nudged along the way. So, you can print it out and bring it to them or email it to them and ask them, even if it's, I don't expect that most will read the whole paper.
But they can flip through it.
They can flip to the parts that's
what
relevant.
they need.
Yeah, exactly. The part that's relevant to what they do and then get something out of that.
I have heard lately, there are some ladies that have managed to get their insurance to pay.
Good.
I actually heard one lady got Kaiser to pay.
I know.
And I think she was one of your patients.
I know more than one. I think in the strategy there was that they got pre-approval from Kaiser to pay.
And was it the same Kaiser that they?
I don't know.
That's just fascinating to me.
And obviously, as we talked about before, for us that do cryoablation, we can't kind of accept the risk of doing the procedure with the hope that we'll be reimbursed, because number one, the reimbursements aren't sufficient for the procedure, in my judgment, and number two, they're unreliable. But in both those instances, the patient got the okay to get reimbursed for the procedure.
Well, I got money back from Medicare. I talk about it in the book that just had my story published, and I had to appeal it. I lost my train of thought. But you were talking about the monetary reimbursement. I only got half of it back.
Right.
And I think and I had 2 ablations. I think the more ablations you have, the less of the a smaller percentage you'll get back if you do with a lot of it.
Sure.
Because the code for it only covers one ablation.
Right.
This, what is it?
Yeah.
0581T.
Yes. Well done. Well done. You know.
I found that on a surgeon's, there's a paper magazine or somewhere, and there was the article online, and it tells you what all the code was.
Right. That is the code for
And
breast
that's what
cancer.
I used it, and I got $7,000 back, or $8,750 or something like that.
So the example of the Kaiser patient that you mentioned is that, she was evaluated, we estimated the cost of the procedure based upon the area that was to be treated, and then she got Kaiser to agree to cover her for that amount. We just had
Which is
had
awesome.
to provide documentation, so she still paid as she would have paid, but at least she didn't have the uncertainty of whether or not she'd get 40 or 50%.
She paid it and then got it back. It
Yes,
was like
yes.
mine. I paid it, and then I went ahead and I got the information off of the Medicare website for the paperwork, and I filed it myself. First time I filed it, they denied it, but they said they needed information from the surgeon. So what I did was I got Allison to just print me out the notes from the day you did the procedure, and I sent that to him. That kept you out of the loop, and I got money back.
Well, there is a cautionary note, however. In both instances, those patients had, and I don't want to disclose information that it will identify anyone, but they had stage 0 breast cancer. They had DCIS, where you have more time to negotiate with your health plan, to ensure that they'll pay before you go forward with the procedure. For most patients with invasive cancer, they don't have the luxury of waiting on one or two or
But
three.
see that I just did it after the fact.
Yeah, you did.
And then I appealed it, and what I found out too was I had trouble getting my secondary to give me their share back. So I called the California State Insurance Commission, and what they told me was you have to find out from your insurance company, are they governed by the state insurance board, or are they governed by the Department of Managed Healthcare? And then once you figure out which one it is, if the insurance company denies your appeal, you can appeal to that authority, and they have the ability to overturn it.
Oh, great.
I mean, I didn't have to go that far, so I don't know how easy it is to do that, but that's what they told me. And I like to pass that on, because then the women have another, but you have to put the time into it. But to me, it was worth it to get the money back.
Well, yeah, it sounds like worth a few hours work or whatever it took to earn $7,000 back. Yeah, so I think we are now over our limit, and so thank you all for joining us again to talk about breast cancer cryoablation specifically today. And if you're available, we can meet again in a couple of months to talk about the importance of timely care, because that has a profound impact on long-term outcomes for not just breast cancer, but for most cancers. So we'll talk about that in the next webinar. Thank you very much. Have a great day.